Hello, everybody. Good afternoon, and welcome to our latest edition of What's New in Neuromuscular Diseases series. Today, we're talking about the new ICD-10 codes for the limb-girdle muscular dystrophies. So to move to the next slide, I'll just quickly introduce myself. I am Paul Melmeyer, and I'm Vice President of Public Policy and Advocacy at the Muscular Dystrophy Association, and we're really excited to bring today's topic to you all as for the last several years, we've been hard at work with many of our colleagues and collaborators on obtaining these ICD-10 diagnostic codes for the limb-girdle muscular dystrophies. So to move to the next slide, I just want to add just a couple of additional notes before I turn it over to our featured speaker, Dr. Nicholas Johnson of Virginia Commonwealth University. But before we get to Dr. Johnson, first just wanted to give a few minutes of background, if I can. We were very pleased to have actually successfully obtained these ICD-10 diagnostic codes for the limb-girdle muscular dystrophies that were announced back over the summer and are now fully functional and usable. They're in the codebook as of October 1st, so a little over a month at this point. And this really was quite the collaborative process that we were very privileged to be part of as we worked with leading LGMD clinicians and medical professionals, some of the leading clinicians at universities across the United States and internationally for that matter, as well as researchers involved in researching the LGMDs. Also partners at the Centers for Disease Control and Prevention, the American Academy of Neurology, and other biotech companies within the LGMD space. Of course, the patient community themselves, as we were seeking to obtain these ICD-10 codes, we had a petition that went out to the community that was to go to the decision makers in the federal government. We had over 700 individuals from the community sign that petition, which was really amazing. So the community really showed up. And then, of course, our partnering LGMD advocacy organizations. And to move to the next slide, you see their logos here in front of you. It wasn't just MDA, of course. It was the Jane Foundation, Speak Foundation, Kurt and Peter Foundation, LGMD2I Fund, Cure LGMD2I, the LGMD, the Limb-girdle Awareness Foundation, Coalition to Cure Calpain 3, and more for that matter, all worked collaboratively over the course of several years to obtain these ICD-10 codes. So a big shout out to them, of course, as they were instrumental throughout in obtaining these codes. But enough about the background. Let's talk about the ICD-10 codes that are now in front of us. And to do so, I'm going to be turning it over first to Dr. Nick Johnson, Vice Chair of Research and Associate Professor of Neurology, Human and Molecular Genetics at the Virginia Commonwealth University. And also joining Dr. Johnson is Anna Smith with the Virginia Cardiovascular Specialists. Anna is a certified coder. She understands the coding world much better than I do, certainly, and perhaps Dr. Johnson as well. But first, I'm going to turn it over to Dr. Johnson. And actually, before I do that, I forgot just a couple notes of housekeeping. For those of you who would like to use closed captioning and you're on the desktop version of WebEx here, you can go to the bottom left of your screen and turn on closed captioning there. Also, we will be taking questions. We'll take your questions on everything that Dr. Johnson is going to be talking about here at the end of the presentation. You can use the Q&A box that you see at the bottom right of your screen. You have to go over and click on those three little dots, I believe, and get to the Q&A there. Submit your questions, and then we'll pose them to Dr. Johnson, to me, to Anna, whomever is the appropriate person to answer them at the end of the presentation. So I think that's it. Without further ado, Dr. Johnson, take it away.
Great. Thanks, Paul. Thanks for the kind introduction. And also, I'm super excited to be here because this really culminates several years of work to get these new ICD-10 codes for us to be available to use. And 100% true. Anna's here to help us with questions because she definitely knows more about coding than I do. So this is what we're going to do. We're going to talk about the ICD-10 codes background for muscular dystrophy. We'll talk about the LGMD classification and rationale for updates, some code-specific changes, and then some take-home communication points for you to use to your staff. So this is what we started with. So these are the ICD-10 codes that we use for muscular dystrophy. And you can see that they fall, G71 includes muscular dystrophy, and where we started, Duchenne and Becker previously called out, FSHD previously called out, and then you have this G7109, which is other specified muscular dystrophies. And you can see their limb-girdle muscular dystrophy linked in there with OPMD, scapuloperoneal muscular dystrophy, the congenital muscular dystrophies, etc. So this, if you were writing that the person had limb-girdle muscular dystrophy, and from a coding standpoint, it would have come back that they had any one of these diseases. So it's not very specific, and it's hard to use for a variety of reasons. So, which is what we're talking about today. So why do we care about better ICD-10 codes? Well, most importantly, these allow for more accurate epidemiological and burden of disease studies. So if you or your fellow in your clinic or anybody else really was saying, gosh, I wonder, how many patients with limb-girdle muscular dystrophies end up having a cardiac transplant. Well, having a specific ICD-10 code allows you to go in and query the electronic medical system directly versus the old-fashioned chart review that many of us were accustomed to during my training specifically. They do facilitate case finding for clinical trials. And then, this is kind of the beginning of allowing us to better understand the burden of disease, the cost of care, and appropriately bill for these exciting disease-modifying therapies that are coming for the limb-girdle muscular dystrophy. So if you have a drug or any type of therapy, it's optimally billed associated with a single IC code. And so that really allows for an overall improvement in billing and cost of care. And if some LGMDs have treatments, they will generate more resource generation. So you can imagine a situation like many of us are hopeful for, where you have, gene replacement therapies that are available in the future. And if that was true, the cost of care for those subtypes is likely going to be different than those without that associated gene replacement therapy. So, this is just going to provide better, more granular detail. In those situations, insurance and pay-for-performance programs may use those codes for cost of care. And then last, and again, just an equally important point is to accurately capture your time and effort according to the diagnosis. So these are the this is the epidemiology of the limb-girdle muscular dystrophies. So these are a group of autosomally inherited neuromuscular dystrophies. They are genetically diverse. There are between 28 and 34 different variants or subtypes of the limb-girdle muscular dystrophy. They all manifest with progressive weakness in the hip and shoulder girdle musculature. The combined prevalence is about 1.6 per 100,000, making these combined the fourth most common cause of muscular dystrophy. Now, the prevalence of that subtype does vary among countries, but the ICD-10 codes that we're talking about are very specific for or these changes are very specific for the United States. And so, the interest in the prevalence here, LGMD R1 or calpain-3 is the most common. Thinking again about that classification scheme, so the subtypes are classified alphanumerically, assigning a D for dominant, R for recessive, and then the 1, 2, 3, 4, etc. is if you can identify the gene name. And this table breaks it down between that dominant and recessive form. So recessive representing about 90% of all patients with limb-girdle muscular dystrophy. Over 24 different subtypes, many more than the dominant forms. And you can see, some generalities associated with these different subtypes. So the recessive forms tend to have a younger age of onset. They tend to have moderate to more severe limb weakness, and they tend to have a more elevated CK. And of course, there are certainly exceptions to those rules, but when you're thinking about the patient that you have in front of you, this might be a way to help you kind of frame out if you're thinking about whether or not it's a dominant or recessive form of limb-girdle muscular dystrophy. So the diagnosis of limb-girdle muscular dystrophy is made by seeing a patient with a progressive proximal myopathy and potentially associated family history. And then you want to do a number of different diagnostic tests. Sponsored next generation genetic testing is typically first line at this point, but a CK can be helpful in terms of making that diagnosis, as well as muscle biopsy, or potentially biochemical testing, or nerve conduction EMG. So why why are we doing this? Why do we care about developing these new codes? So as I said, this will allow us to differentiate some highly prevalent subtypes. It does have the potential to impact management. So again, thinking about the more specific the code, the more you're able to clarify that resource utilization. So those subtypes with more cardiac involvement could be separated from those without cardiac involvement. And you could imagine if you're doing a cost of care or burden of disease study, that would be important to be able to ascertain that appropriately with precision. And then, the most exciting reason to do this is to start to think about streamlining treatment with subtype-specific gene therapies in development for limb-girdle muscular dystrophy. So these are some variety of different clinical development programs on a variety of different biopharmaceutical websites, but you can see many of the sarcoglycans, dysferlin, FKRP, ANO5, calpain-3 all have some form of gene replacement therapy, either in the clinic or in a preclinical phase. And there's additionally a small molecule therapy in development for FKRP or LGMD-R9. So this rationale here was the same thing that we shared with the ICD-10 committee to be able to propose separating out or specifically subtyping some of these different limb-girdle muscular dystrophies. This is, if we were live, I would have asked for a drum roll, but you can't do that on WebEx. So just the suspense is over. These are the new codes. So you can see how they're broken out. So you can now code specifically for an autosomal dominant limb-girdle muscular dystrophy. You can also code specifically for several subtypes of recessive limb-girdle muscular dystrophy. So LGMD-R1 you can see called out there, LGMD-R2. You can code for the sarcoglycans unspecified, so LGMD-R3 through R6, or you can code specifically for alpha beta sarcoglycan, or if it's a gamma or delta, you could also use that R5, R6, the G71, 349, due to other sarcoglycan. You can code specifically for ANO5 or LGMD-R12. You can code for any limb-girdle muscular dystrophy, either as other or as unspecified. So this is probably one of the 2 take-home slides. These are the new codes. They are effective. They're in your clinic right now. And so when you're typing your diagnosis in the medical record, if you provide this granularity, the coder associated with that encounter will be able to code specifically for this. If you were adding it up, that was not 28 different subtypes of limb-girdle muscular dystrophy that you can code for. And so despite the efficacy, you can see there are some that are specifically missing. And most notably, if you're matching up your slides and paying attention, LGMD-R9, which is a fairly prevalent form of limb-girdle muscular dystrophy, does have therapies in development, which were really our 2 rationales to be able to use the new codes was not included. So there are advocacy efforts underway to add it in the next cycle. So, but just to call out that we're aware that LGMD-R9, 2I, or FKRP was missing from this. So what do you need to do about this? This is the second take-home point of the slide. So first of all, please document this in your encounter note. So your coders, like Anna, use the information in your note to be able to accurately generate the code. So you need to add the text into your assessment. So that can mean including the gene name specifically, the subtype specifically, or really any other information to assist codes. Like, for example, I know this patient has limb-girdle muscular dystrophy due to a sarcoglycan mutation. Additional variant testing is underway. That's probably enough to be able to get them to that sarcoglycan code, for example. And then be prepared and be aware that with these no codes, you may get queries from your billers or your coders to be able to help them better granulate the diagnostic code. You can educate your multidisciplinary staff. In fact, we will tomorrow morning at our team meeting. So you should communicate these changes to your local multidisciplinary staff. You should increase awareness to other clinicians, let them know that these are available. And then as Paul and his team get underway for advocating for those missing codes, please participate in those efforts if you're able to help support that advocacy to include that inclusion of those missing codes. And I think that is it, and we are open for questions.
All right, thanks so much, Dr. Johnson. Yes, excellent presentation. Please, if anybody has a question for Dr. Johnson, for me or the Muscular Dystrophy Association, or if you have a very esoteric coding-oriented question, that's why we have Anna here to help us out. As you're thinking of your questions, just to kind of reiterate a couple points that Dr. Johnson said, if I may, since we have a few minutes left in our half hour. Even though we don't have targeted treatments available, FDA-approved treatments as of yet for these LGMDs, it's still incredibly important to be using the specific code that matches the diagnosis so we can better understand prevalence, so we can better understand the epidemiology of these diseases, so that we can better understand the progression of the LGMDs. And this is the precise reason for why the CDC was part of this initiative. They understand how important it is to have ICD-10 codes specific to the genetic diagnosis. It makes the research and understanding of these neuromuscular conditions so much, it increases understanding and facilitates research so much further than if these ICD-10 codes are unavailable, because otherwise all the LGMDs are lumped with these other muscular dystrophies, and we don't have a good way to track and to better understand for that matter. Okay, we have a question in the Q&A box, which I'll read. This is from Angela. How easy will it be will it be in the future for other forms of LGMDs without codes to obtain their own specific codes? So that's a very good question, and I can start since I'm familiar with the process at this point after having worked with Dr. Johnson and others, of course, for the last several years. So the way that LGMDs have been added into the code book, if you will, allows for additional ICD-10 codes for the LGMDs that do not have their own subtype-specific code to still be added. There are holes. There are holes essentially in the list so that we can plug in whether it be LGMD R9 or 2I that Dr. Johnson already mentioned, or the many other LGMDs that don't have a subtype-specific code. We can work to plug those in going forward as clinical understanding, clinical development of new treatments advances within these LGMDs. Now, one complication of all of this is that eventually, sometime down the road, we're going to be transitioning from ICD-10 to ICD-11, and ICD-11 is a whole different system, has a whole different construct. So it may be that we'll have to revisit some of those at that point. But at the very least, Angela, it can be a challenge, I would say, because already the decision makers that decide on who gets an ICD-10 code and who doesn't have already decided these are the ones that should, and all the other LGMDs, at least at this point, should not. But that doesn't mean that we can't be revisiting that decision and be advocating for the additional LGMDs down the road. And logistically, within the code book itself, there is room for them. So it's a long way of saying it will be a challenge, but certainly not impossible, and certainly something that LMDA would want to be involved in going forward. Okay. I'm not seeing any other questions at this moment. We'll maybe give it just another minute or two for anyone to ask any questions. While we're waiting for that, Dr. Johnson, any additional closing thoughts for any clinicians or other medical professionals who may be on the webinar today, or going to watch the recording of the webinar, and they're considering how they want to be implementing these new codes within their clinic?
No, I think it's just to emphasize, provide as much granularity as you can where you are in the diagnosis of that patient within your assessment and plan. That allows the medical coders to extract the information appropriately. So, if you can tell if it's dominant or recessive, if you can, if you have a guess about the subtype but you're not quite sure, those kinds of things can be quite helpful.
Very good. All right. Well, we may just have the one question for today, that being from Angela. So, Angela, thank you for the question. Oh, I'm seeing, I think, one more coming in, and that's, is having an ICD-10 code for a medical condition a prerequisite for the process of healthcare reimbursement? So, how important is it for that ICD-10 code to be there in order to facilitate reimbursement? I'll turn to Anna actually for an additional thought on this, but Dr. Johnson, perhaps I'll start with you for your experience on how important it has been to have an ICD-10 code specific to the diagnosis in which the care you're seeking to deliver for that genetic condition is in question.
So I think this is really just kind of we're at a foundational point now where we're beginning to implement these codes. It will become much more important as targeted disease modifying therapies, which have the potential to be quite expensive, become approved by the FDA. Because in those situations, you may have a pay for performance or some other situation where you would need to be able to accurately code for that bundle and demonstrate the overall resource burden, in terms of that particular treatment. Anna, do you have any other thoughts about that?
So thank you for that question. It is extremely important, like Dr. Johnson said, because research is going to be developing new treatments in the future. So it's very important to choose the specific diagnosis that corresponds to the specific treatment. And yes, so also Medicare, the main condition of CMS and Medicare is that we document diagnosis more specific and more accurate for the patients. And it kind of reminded me of what Paul said in the beginning, that 700 signatures were obtained from the people, from patients. So this says a lot that the patients want new treatments. They want this to be more specific from the diagnosis point of view. So there's a real need out there for this diagnosis to be documented in the medical records.
That's very well said, Anna. Thank you, and well said to you as well, Dr. Johnson. All right, last call before we close out our half an hour today. Not seeing any, so I guess with that, I'll just again thank you to our two panelists here, Dr. Johnson. Your collaboration throughout and your presentation today are invaluable to the effort. So thank you again. And Anna, wonderful for you to join us today. Thank you for your expertise on all things coding. You've been incredibly helpful
Oh, no
to us.
problem. Thank you. It's my pleasure.
Have a great rest of your afternoon or evening.